Hello, everyone. So I just want to make sure everyone can hear me. So if you can, please put a comment. Just checking that everyone can hear me before I go ahead. The last thing you'd want is this to be recorded and no audio. So just let me know in the chat if you can hear me. Beautiful. Okay. Well, let's get started. This will be recorded and it'll go up to our YouTube channel. So, for anyone that can't make it, because it is a really awkward time of the day, especially for anyone that's living overseas, all this information will be there. If you don't already know who I am, my name's Caroline. I'm a medical doctor in Australia. I'm an international medical graduate and I actually did do my medical internship in Australia. So, I have a podcast that is about medical internships and really everything you need to know about making a decision whether or not you should try to continue doing an internship back home or trying to do one in Australia. So I really suggest you also listen to that because internships are quite different to every other job. Or should I say, it's different to obtaining any other type of job in Australia. It's a lot harder because there's just not as many places on offer for international medical graduates. So you really need to know sort of the statistics and the chances so you can make the best decision for yourself. So, how we're going to structure this podcast is I'm going to tell you about my experience in the internship, and I'm going to go through all the details, all the rotations I did, what the structure was like, what the support was like, and sort of any issues I came across. And then I'm going to answer some questions that came through on our Instagram and our Facebook. But obviously, if you have some questions, you can still post them here in the live, and I'll read them as I'm talking and answer them. So let's get started. I wrote some notes on my other screen here because trying to remember the details of my internship. I want to get it right for you guys. So the first part we're going to talk about is looking for an internship. So I graduated in 2017, and it was at the end of 2017. And so obviously I had to go through the process of sitting my AMC1, studying for that. So I did that. I passed that. And for me, I needed a medical internship because I hadn't done an internship within my degree. So at this point, the anxiety was high because I was talking to other colleagues who were trying to get internships, and there was just absolutely some horror stories. So everyone was like, "Oh, you're just better off going back overseas, doing your internship there. Don't waste time here. You know how difficult it is to get one here." And I was just thinking, "Oh, this is a nightmare." Like I my source of information was just everybody else, and their source of information was other people, and their source of information was some Facebook post. So it was just negative, 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 negative. And honestly, there was no hope. So anything I did hear, it was just word of mouth. And some of it was incorrect and some of it was correct. And you just don't know at the time because it's the blind leading the blind. So then I was told, well, apply through Queensland Health because Queensland Health campaign. So Queensland's one of the states in Australia. And if you're not already living in Australia, every state almost feels like its own country. So we don't have one universal system that you can apply to and then it goes to all the states like one database. You have to apply to individual states. So everyone was saying apply to Queensland because they actually let in IMGs apply for internships where, say, for example, the other states, New South Wales doesn't let you, Victoria doesn't let you. So that's what I was hearing. And so I was like, okay. So I applied through Queensland Health and during their campaign. So they open up their campaign. Every state's a little bit different, but they open it up mid-year for the following year. So that's what a campaign is. So they open up the internship campaign and you submit a CV. Sometimes it allows you to submit a cover letter and you then just wait to see if you're contacted. So that's really just how it happens. And so I did that and I wasn't contacted. And so I was like, oh, this is a nightmare. I also later in the year started contacting a few hospitals and emailing or ringing up. And also they said, sorry, like we've got our interns for the year. So that's why it's really important to understand that this is not like a resident level, PGY 2, 3, or 4 job. An internship, they don't have many of them. So they've got probably around like 2,000, 2,500 a year, but they're graduates from their own medical schools. Let's say, I don't know this number to be exact, but let's say it's also like 2,450. So there's just a very, very small amount of positions available for international medical graduates. And in actual fact, they never take on an international medical graduate unless they're absolutely desperate and they've exhausted all other avenues, meaning there's no local grads left to give it to. There's no international students that have studied in Australian medical schools to give it to. So now, like, they're forced to give you one. So you're really relying on the local graduates or the international students to not want an internship that year. Some people decide that they want to take a year off and travel. They did all this med school and now they just want a break. Some people decide to, do medicine overseas. Some people decide that they're going to go to another state. So these positions don't open up very frequently. And if they're going to open up, it's not all year round. It's going to be like sort of at the end of the year. The reason being is internships, like most other jobs, start at the end of January. Each state's a little bit different yet again, but roughly it's at the end of January. So very rarely will you have an intern working, say January, February, March, and then quit and a position becomes available. Very rarely. It does happen. I'm going to give you an exception, but very rarely. So your chances, I guess the moral of the story here is your chances are extremely, extremely low. So not impossible, but a lot harder than your PGY2 jobs or your PGY3 jobs, which is a resident job. So I just need you to factor that into your decision making. So I knew that when I was approaching. I knew my chances were really low. I was telling my husband my chances are really low. And I was slowly mentally preparing to leave the country and go and do my internship overseas. So then it was January, February, and I said, yep, okay, I'm definitely, this is it. The interns have started. I'm not going to get an internship. So I started applying for internships overseas and I was ready to go. I registered myself with the medical board overseas. I was planning everything and it was a massive sacrifice because my husband isn't a doctor. So for his job, he had to stay in Australia and that's what we're going to do. I was going to go overseas for a year and he was going to stay in Australia. And so I'm telling you, other than the ticket, I was ready to go. I had my registration, overseas registration, that is. I was planning my accommodation. I just hadn't bought the ticket yet. And then I get a message from a friend who she's an international medical graduate. She got an internship because a position opened up and they snatched her because they needed to fill the position before the year started and they grabbed her because they were desperate. And so she said, hey, I've just heard through the rumor mill that one of the interns here has quit. And so dare I say there's going to be a position available. Contact this hospital ASAP. And I was like, what? Like, this is unheard of. An intern working and quitting like mid-year or at the start of year is unheard of. So I was like, okay. So I contacted the hospital. Now, you got to remember with internships, they need to fill in the position like as soon as possible. So, because they don't have many interns as it is, not like resident roles. So, if a position comes available, they need to staff it as soon as possible. So, with internships, it's a bit of strategy, but it's also a bit of luck, right place, right time. And that's what I was, because I had the inside information. I could have the right place, right time scenario happen to me. So I contacted the hospital and they were like, yes, actually something has come up, send us through your CV. So I sent through the CV, and look, I can't remember how long after did they say, look, we'll interview you. And then they're like, we're happy to do this interview online. And I was like, no, 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 I'm happy to fly down and interview. Oh, you don't have to do that. I'm like, no, 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 I insist. The reason that was a bit of strategy, because I'm much better in person. My skills, I've always known, is how I come across in person. So I was like, I need to use this one thing I've got to my advantage. Also, I'm a big believer, when you got one shot, you got to give it everything you've got, because I hate living with regrets and I hate thinking like I could have done better. So I was like, no, I'm flying down and you're going to meet me in person, because impressions go a long way. So I flew down, and, I tried to prepare for the interview as much as possible. I asked my friend, like, what did they say on your interview? And she said nothing really. There was just like, tell us a bit about yourself. They didn't even ask me a clinical question. And I was like, oh, okay. So that was weird, but I still tried to prepare for everything, like a clinical question. So that's what I did. Even though like my friend had a different experience. I flew down. I was so incredibly nervous. Like, I do good in interviews, but because everything was on the line, and my IMG friends who have done these interviews know exactly what I mean, you're not yourself. You're really not yourself. So I was so nervous. I was like, honestly, I think my stomach was like out of my body at that point. And I was just like, oh, just feeling so ill. But I thought, no, I'm going to give it everything I've got. So I just snapped out of it. It's just one of these techniques I used to do when I used to public speak. I used to do debating when I was younger. I was a very shy girl. And this was just a technique I used to use to go in and deliver, not be myself, go in and deliver. So that's what I did. And, they went and proceeded to ask me a clinical question. So the questions were like, tell us a bit about yourself. Have you ever been here before? Have you ever been to this state? Why this state? What do you bring? And then they gave me another scenario. Tell us about an issue that you had with a coworker in the past. Then they gave me a clinical question. And this is where I would say most IMGs, their pitfall is this clinical question. And it was my pitfall too, because you're putting so much pressure on yourself. You feel like you need to answer everything perfectly. And now that I've been on the other side, working in admin, being one of the interviewers, I now see that that's not the case. That's not what they want. They just want to see that you have structure, and you're in control of that structure, and you're in control of your sentences and how you will proceed with that clinical scenario, instead of like, oh, I'll do this, I'll do that, but then they'll go back, oh, but let me go back here and actually do this and do that. And you're not forgetting the basics. Everyone always forgets the basics in the clinical scenario, in the interview. So I, now knowing what I know, like, it is so easy to master these interviews. But when you're in that state and you don't know, you let yourself down. And that's what I felt I did. I felt I let myself down in that area. And I walked away and I was like, oh, I don't know. I don't think I did that great compared to how I normally deliver in interviews. I don't think I was that good. And I tend to be a little bit hard on myself. So then I get a phone call, and no, I got an email. Sorry, I got an email saying, "Hi, this was a really hard decision because you interviewed great, but we've gone with someone else who we just felt had a bit more." To bring to the role, something like that. They said so. It was really difficult because devastated the country, not go overseas and do an internship, and I was absolutely shattered, like um, without a doubt, as you can imagine. So I was like, oh, this is just just horrible. Like, and I thought, why, God? Like, you gave me feeling like I had hope, and then you took it away, and I hated that feeling. So, and obviously, I felt very like down on myself because I know interviews are my one thing that I definitely deliver on. So then, like 2, 3 weeks later, I get an email saying from the hospital saying, "Hi, Caroline. Look, the other person fell through, and we'd like to offer you the position." Like, talk about luck, right? And I'm not a lucky person. I'm not a lucky person. But I was like, "What? What?" Like, I could not believe my luck. But apparently, their visa was an issue. I was in the country. I'm an Australian citizen. And I think that's what taught the admin person that, it's easier to take people that are already in the country for last minute internship positions and last minute resident positions, because you like the visas adds another factor of delay and another factor of complication. And when you need somebody to fill in the position now, you can't really be relying on visas. It's different when you're applying in a campaign and they're doing it 6 months before you need to start, and they've got plenty of time. So that I got it, and I could not believe my luck, and I was almost like I didn't want to celebrate because I was like, nah, until I actually get my registration. Because in Australia, once you pass your AMC 1, you don't apply for registration. You're only eligible to apply. So then you basically have to look for a job, you get a job, and then you start the application process for your registration, because the hospital has to provide documents as well, because essentially they're supervising you. So they need to provide these supervised plans to APRA to get you registered. And so I was like, I can't celebrate till I know this is in the bag. And so I started my process, lots of documents involved. And it took 4 months at the time. Now it takes even longer. It takes like even 6 months because of COVID and things slowed down. I wonder if it's getting any faster this year, but like for the last couple of years, it's been really slow. So then I basically got told, your application's almost done. You've got to do a in-person check, which is you present to an APRA office. They look at your license or your ID and they're like, yep, you're you. Cool. Done. 2 days later, you get your registration. So I was at that phase and I was like, okay, this is it. This is in the bag. And so I proceeded to move down. So I basically got offered the job in maybe April, and by May, so it took about 4 to 6 weeks for me. In May, I was starting mid-May. And so obviously I was extremely nervous. I tried to prepare as much as I could by asking around, but honestly, again, it's like the blind leading the blind. Any IMGs that had just started doing their internships also were just learning as they go. So blind leading the blind yet again. So, and anyone that's actually well ingrained in the system by now is just too busy to even like answer your questions. So they're just basically trying to survive the hospital system. So there wasn't really anyone to actually get a lot of insight from. So I moved to, now I can tell you, I moved to Tassie. I moved to Tassie from Sydney. My husband, again, not medical, and his job would not work in Tassie. So again, we made the sacrifice that I'll move to Tassie, he'll stay in Sydney, and he'll just visit me like every fortnight for the weekend. And in hindsight, that was actually brilliant for me because I could put my entire focus on really not just surviving the hospital, but like this is our slogan, like thriving in it. I didn't want to just keep my head above water in the hospital. I wanted to actually swim and do well. So if that meant I stayed back, I stayed back. If that meant I spent my nights, I came home, I ate dinner, I read up on something, I read up on something. I didn't feel guilty like my partner had moved down, my husband had moved down, and he's basically left alone on his own. And I'm like doing my thing and we're two ships in the night. Like I didn't feel any of that guilt because it was just me. And that was actually really good in a way. Yes, I missed him and there's that aspect, but mentally I could focus on what I needed to. So I did that. And where did I start? Okay. So I've got my list here. Okay. They put me in. So actually, before I say where I start, I want to explain to you the internship structure. So if you're an IMG and if you've heard this term, 47 weeks of supervised practice, what that means is that in order to get your general registration, one of the many requirements is 47 weeks of supervised practice. And the AMC wants it in at least 10 weeks of medicine, 10 weeks of surgery, and 8 weeks of emergency medicine, and the rest can be in whatever. But you have to not just work in those departments, you have to pass those weeks. How do you pass those weeks? You pass them with your end of term assessments. And I've done a little reel on this. You need to know what they are before you start working. I didn't. Most IMGs don't, and you just go in blind. And you can actually come across a few issues with those. So you need to know what's required of you to pass and get your general registration, so that when it does come up any issues, you know how to tackle it. Because a lot of IMGs have suffered and failed because of these things, because of not knowing. So with an internship, it's easier because you're automatically given those rotations. So you're automatically given a term in medicine, you're automatically given a term in surgery, and you're automatically given a term in ED. So you will already satisfy the 47 weeks of supervised practice in those terms. As long as you pass, you're fine. Versus if you're a resident and you might not get those terms. You might get 6 months of ED, a month of surgery, and a month of ONG. A term of ONG. You might not get your term of medicine, surgery, and ED in the first year. So that means like it might take you 2 years to do the 47 weeks of supervised practice. So with an internship, it's automatic. It's automatic. You get it. There's no debating. There's no asking. There's no requesting. You get it. Done, which is good. So where did I start? I started in general medicine, maybe like halfway through the term, because by the time I got my registration, they were halfway through their term. And literally I got my registration. The hospital emailed me, you're starting the next day. Okay. We're going to send you to a Gen Med ward. There's one other intern there. It's really busy. And this intern's been requesting that they have another resident, they have another junior doctor to come and help. So they sent me. Brand new. Don't know the system. It's a busy department. This intern's requesting help and they send me. So put yourself in the local shoes, the local graduate. How annoyed would you be? And this is what happens to them a lot. So like I do say things about local graduates, but I also empathize with them a lot because you got to put yourself in their shoes. And I honestly, didn't know a single thing. It's not about the medicine. It's about every other task that you need to do. That's what makes you a junior doctor. That's what makes you a good junior doctor in those rotations. It's not about the medicine. So these local graduates, they are like learning as medical students in that hospital for 3 years, and then they become interns. They know where every single form is located on every ward. They know what this referral form looks like and what that referral form looks like. They know where this department is and where that department is. So when they're doing a task, it takes them honestly 100 times, it makes them 100 times faster than what you ever could be. So when they're like, okay, I need to refer to outpatient clinic, they go, they grab the form and you're like, okay, what form does that look like? What am I looking for? Okay, find somebody to ask. Oh, hi, the ward clerk, do you have an outpatient referral form? Okay, how do I fill this out? Okay, where's the fax number to send it to? Everything is hard for you. And these guys are just doing it like this. So you got to understand it's not the medicine. It's every other thing that makes you a good junior doctor that you cannot do. And that's where it's overwhelming and you feel like I'm hopeless. I'm honestly hopeless. And then if you have a local doctor that isn't very kind or understanding and makes you feel even worse, factor that in. So that's what was really hard. So I was lucky that if she did have a problem with me, she wasn't very vocal about it. Great. And she wasn't like very catty about it amongst the other interns because they all talk. They've gone to medical school together. They're like a big group, big high school group. And so they all talk with one another. They all share stories. So like I was kind of glad she didn't do that. And if she did, she probably just shared it amongst her close friends and they were quiet about it. So in that sense, I felt like I had a pretty supportive environment. And hey, if you're listening, thank you. Because you probably didn't even realize how comfortable you made it for me, but you did. Um, so um, so with the structure with general medicine, this is how it usually goes. Your ward rounds tend to start around 8 to 8:30. So you get in there earlier, and you do the patient ward list. So that's a big sheet that we all carry on our ward round, and we go to patients, and it's got all their details and things like that. So you've got to update it, and you've got to add the new patients that got admitted overnight onto the list. And then you go do the ward round with the registrar and the consultant. The ward rounds are longer because this is medicine and they're a bit more thorough. So they're going to see the patient, they're going to talk to the patient, they're going to look at everything. And for me, I personally think if you're a brand new IMG, starting in general medicine is beautiful. It's brilliant because it's slow paced, and you've got your registrar, you've got your consultant, you've got your other residents, whether they be interns or PGY2 residents. So you've got your other junior doctors. That's the umbrella, junior doctors. And you get to really feel supported and not so much pressure. So I thought it was brilliant where I started. I personally, that's where I recommend most IMGs start. Now, hospitals sometimes can't do that for them because they need them in ED, so they go off to ED. So then you like do your ward round, and then the jobs come out of the ward round, and you sit with your registrar and they're like, all right, so this patient needs a referral. This patient needs a surgical review. This patient's good to go home if after this test is normal. That. So you start dividing up the jobs. You do the jobs, and your registrar might want to make sure that our connection is saying it's unstable. So just don't want to keep talking if we're not recording. Oh, we're back. Okay, great. So that was a really good supportive environment, and you like don't need to make any big decisions because you're not meant to. That's not your job. But your registrar is there to always ask questions, and you have your other junior doctors for support to ask questions. So you do your ward jobs, and then you do your discharge summaries in the afternoon, and you get organized for the next day. So that was brilliant in that sense. But spanner in the works, let me tell you. I was just a few weeks into general medicine, and I got an email from the junior doctor admin person saying, we're going to move you because one of the girls in surgery is going on leave and we need you to replace her. And I was like, damn, okay, but I'm still finding my feet in general medicine. And like, also it seems counter. If you need to replace somebody in surgery, wouldn't you replace them with somebody who's been in the hospital for longer than 3 weeks? So why I'm sharing this is that this is a common occurrence that happens amongst IMGs, and I'm going to explain why. So they wanted to move me to surgery. Surgery is very, very intense. Surgery is absolutely horrible for any new IMG to start out there because it's very unsupported. I'm going to talk about it, the structure a bit more later, but it's very unsupported. And and everything's like go, 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 go. Yesterday. Have you done it? Yesterday. Not now. Have you done it yesterday? That's how fast it moves. So to send me after 3 weeks, it felt like I felt like I was being set up to fail, honestly. I felt like that just does not make good sense. Like from a perspective of like, if surgery is very full on, if you need it well staffed, you should staff it that have been in the hospital for longer than 3 weeks. Now, this is what I mean. I'm not going to say the word bullying because that's not what I mean, but where the culture comes into play that can be so negative for international medical graduates. When the local doctors in the surgical unit that I was meant to go to heard that I was going to come, a brand new IMG, minds were blown. Drama. Oh my God, what? So they went into a panic. No, like this is a busy unit. We need somebody here that's like knows what they're doing. Fair enough. I actually agree with that point. I agree. I felt the same way. Fair enough. But instead of, I don't know, like discussing it like adults, they all rallied together and somebody emailed the administration person, demanding that I don't get sent there and that they get sent somebody who knows the hospital better. Which again is a fair point. It's a absolutely valid point. It's just the way it was done I don't agree with. But once again, you're dealing with 23-year-olds. This is usually their first. Most of the time they're 23. Some of them are actually older, but this is their first job. This is the first time that they're actually having to work with people, of all different backgrounds, of all different experiences. And so you've got to be fair. They don't know how to navigate these things. They don't know how to navigate it except in the way of this high school behavior. So, like, just remember, if you're going through a bad time, remember who you're dealing with and give them some allowances for that. But and I remember even one of them approaching me in the hospital quarters, the doctor's rooms quarters, and it was just honestly like a scene out of high school. I was like, um, I I mean, how old do you think I look? It's quite flattering if you think I look really young, like I look 24, 25. You think you're gonna like step all over me because you're not. But I was just like, okay, this is ridiculous. And so it was quite clear to me that they were highly strung about me coming, and that it was quite clear when I got that email from the admin person that they had said something. And so I just want to let any locals that are listening to that, it wasn't very nice because I'm here trying, I understand your concerns, but I'm also here trying to make a good impression. And what that did is just made me feel like such an outsider. And it hit me in the guts a bit. And that's not a great experience for anyone. So, like, sometimes a bit of putting other people in your shoes, putting yourself in other people's shoes is really important. But a lot of times they don't have that because they've grown up in this hospital. They were students in this hospital. They've never worked anywhere where they're the new guy. And so they just do not have that empathy. They do not have that understanding. So anyway, the admin person emailed me and said, look, we're not going to send you to surgery. We're going to send you to respiratory medicine instead. So basically, they left the person in, or they pulled somebody else out, put them in surgery, and they sent me to fill in respiratory medicine because then there would have been still a gap somewhere else. And I was like, okay, well, at least respiratory medicine, general medicine, it's a bit similar. However, the fear was that the consultant for respiratory medicine was one of the big players at the hospital and was also the head of basic physician training. So if you had in your mind you wanted to get onto general medicine training, which is called basic physician training here, this person would have to endorse you. And then on top of that, their registrar was like the golden boy of the hospital. So their registrar was somebody that was one of the medical students, has been attached to that hospital for years. Then they were an intern there, then they were a resident there, and now they're a registrar. And I was like, wow, if I make a fool of myself, it couldn't be to the two worst people. Like basically that this person would say I was terrible resident, and that would spread like wildfire in the hospital. And I was freaking out. I was like, oh my God. So yes, I went into it just so intimidated. And that was always in the back of my mind. So I did 1 week on respiratory medicine and then I went back to general medicine and I continued. And then I get another email a few weeks later that respiratory medicine has a gap in, they need a resident because their current resident's going on study leave. And they've requested you. What? Why would they request me? The registrar and the consultant want you back. What? I was like, what? Like, it didn't make sense to me. I was brand new. Why would they want me back? And so when I went back, the registrar was like, yeah, we were really, really happy with the work that you did. And so when you were going to get another resident, they're going to send us somebody else. We said, no, send Caroline back. And I was like, what? Okay. So that was a shock to my system. And just fast forward, a year later, I had a conversation with this registrar who's now one of my good friends. And, he said some really like amazing advice to me. He said, Caro, we liked you, because it's not about the medicine. It's not about the medicine. It's like he goes, you can take anyone off the street with common sense and put them here as a first day on the job as a doctor, and they would do better than some of our, doctors that have been working for a couple of years that don't have that initiative, don't have that common sense, don't have those soft skills. So he was talking about soft skills, communication, organization, prioritization. And he's like, you did so well in that. And we saw that. And that's why we wanted you back. And like, basically saying you got to give yourself more credit because, you are freaking out, but people see this side to you. And it's true. Like I thought about it and I'm like, when they asked me to do stuff, I just did it really well. Like, for example, when they said, "Oh, are you comfortable with ABGs?" And I was like, "Yeah." I used to work as a phlebotomist. I used to train as in a college for people who wanted to become phlebotomists and get their Cert 3 in it. So ABGs were like what I used to do for work all the time in hospitals. And they said, okay, because we're weaning this patient up oxygen and we just want to see the stats. Could you go and basically do a timeline and, just see how they're trending? So when I wrote my patient notes, best believe that was the best patient note they've read. And with all the trends, the times, the oxygen stats, the VBG, the ABG results. And it was things like that. And when I was communicating the plans, I was super organized. That made their life easier, that they just loved. And so that's what I mean. These soft skills work more in your favor than your clinical knowledge. I'm telling you now. I'm like proof of that. So it's so important to have. And being not my first job, being an older person, that was my superpower. And I knew that going in, and I was going to always play to that superpower. Okay. So I'm a really good communicator just with life experience. I'm older. I've worked before. Like I just know how to communicate with seniors. I know how to problem solve. So I was just going to use that to my advantage. And obviously it won a few people over. So I went to respiratory medicine. I came back and I finished up my general medicine. I gave them my end of term assessment and they gave it back to me. I didn't know what any of those numbers meant, but I passed. But I didn't know what a 2 or what a 3 or what a 4 meant. Like if I got a 2 and they still circled satisfactory for end of term, did I pass? I didn't know what that meant. So like this is what I mean, how naive that you could get yourself into so much trouble if you don't know what you're signing. You don't know what form, you don't really know the ins and outs of what is required of you to pass a term. So then I got sent to rehab ward. So at this point, I haven't done 10 weeks of medicine. Remember, I've only done six weeks because I started halfway through the term. So then I get sent to rehab. So rehab still counts as a medical term. And a lot of people don't like to go to rehab. It's boring. It's boring. My God, it was one of the best rotations. And I highly recommend it for international medical graduates. And if you're not finding it, it's good. You're doing something wrong. The reason being you only get 2 ward rounds per week. And you get like some subacute patients there. But you get 2 ward rounds a week. They tend to be very long. And so the consultants usually have time to talk to you. Before those ward rounds, you sit in a multidisciplinary team meeting, an MDT meeting with the occupational therapists, with the physios, with the nurses. And you're just, because, rehab, everyone's involved. And you're discussing this patient's care and when you think they will discharge and what they need. While you're sitting in these meetings as well on your rotation, you're learning the occupational therapist acronyms. This person can mobilize with a FACEF. This person can mobilize with a SPS. And you're like, what the hell is that? But you're learning, very important, you're learning how to discharge plan. Really, really important, because discharge planning is not something that is done overseas. Your discharge, go home. I don't care how you get home. I don't care if you're unsafe at home. It's not my problem. Here, it's our problem. It's our problem. So you need to discharge plan. Like, oh, you don't have services at home? Who cares? Here, it's like, oh, okay, you don't have services at home. You're elderly. How do you do the washing and cooking? We can't discharge you safely. So you'll need to stay in hospital. We'll need to get an ACAT assessment and we'll need to see if you're eligible for services before you go home. This is a whole nother side of medicine and you need to know it. So this is where you can learn it in rehab at a slower pace. So it was brilliant. That you can also like, it's slower pace, so you can learn more of your clinical skills, your venipuncture, your cannulation, your urinary catheterization. So you can sort of like not feel so much pressure. Um, I think it was a brilliant, brilliant rotation. And I would go back to rehab even now as a resident in a heartbeat. In a heartbeat. Loved it. So I've passed that. And then so now I've done more than 10 weeks of medicine, but I've passed. So I've ticked 10 weeks of medicine. So then I went to, where did I go next? Where did I go next? Aha. Okay. I went to GP land. So remember 47 weeks of supervised practice with 10 weeks medicine, 10 weeks surgery, 8 weeks of emergency medicine at least. Now, they gave me a term of medicine, they gave me a term of surgery, they gave me a term of ED. In my hospital, you did 4 terms a year, 13 weeks each. Some hospitals different, they're 5 terms at 10 weeks. So I did, so they sent me to GP land. So GP does not count. So even if I passed it, it did not count to my 47 weeks of supervised. Sorry, it does count to your 47 weeks of supervised practice, passing it, but it is not medicine, it's not surgery, and it's not ED. Okay, so it's something else, but it doesn't have to be any of those things. So I got sent to rural GP, so an hour away from the hospital. So you had to live there. And so there was a little bit of a story around this where basically where I felt a bit forced to go there. So what rotations I was doing was the person who quit, I was replacing their rotations. So this person was obviously going to go to rural GP for 1 term, and I was going to replace that. I had no problem going away for 1 hour. No problem. The issue is I had my dog, that guy. I had my dog with me. And so the accommodation they were going to put me in wasn't allowing pets. And so I was like, well, it's a 13-week rotation. I have my dog with me and my dog can't come. So I don't know where you think I can put this dog. Like, it's like my child. Like I can't just abandon it and leave it at home. And then also if I had a child and said, well, I'm a single mum and I care for my daughter and I pick her up after daycare, so I can't stay there, what would you say? So it was kind of like I tried to explain that and I wasn't feeling very heard. And then I got a phone call from the director of clinical training. So that's your boss. And basically, just wanting to know how committed I was. And like, just want to make sure you're committed to this rotation because we don't want people going if they're not committed. And I'm like, it was a kick in the guts because I was like, I've never had anyone question how hard working I am or how committed I am to any job. So it was like, I felt like really low that day. I felt really low. But factor in the director of clinical training didn't know me at that point. I was still brand new. They hadn't heard of me. They've seen a picture on the wall and they say in their office, Caroline. Okay, that's it. They don't know me. So yes, I give allowance to that. But I guess when you're an IMG, like you just want to prove yourself so much that when you get these days where you get phone calls like that, it just knocks you back. And I guess it's a bit of insight to admin people if you ever listen to this or locals. Like you've got to understand the I guess the mentality of an IMG. You've got to understand the emotional side of what they're like harboring when they come into a role. And so that's why a supportive environment is extremely important. So I ended up still going to this rotation. I had somebody looking after my dog. And then when I went to the rotation, the accommodation was not great. And they wanted me to stay there. For also safety reasons, the roads weren't that great. So driving to and from, a previous person had passed away in a car accident on the roads there. So obviously it was coming from concern. But the accommodation, now factor in, I didn't just come out of medical school. I'm not, a medical student living basically with the bare essentials. I used to do that 10 years plus. Now I'm like moving 10 years forward, I'm used to comfort. I'm used to a certain level of quality of home. And security is really important for me. I like had a break in the past, and this person got into the house, and forever since then I literally have to go around checking all my windows and doors all the time. So like for me, security, especially being a female on my own, was paramount. So when I got into this accommodation, it was like, oh my gosh, the security on the door was like a little button. So if I just came and knocked this door, because it's an older house, the door would have flown open. And everything, like the kitchen, the bathrooms, was just no, I couldn't like live like that. I was over 30. I'm used to a level of comfort. I could not live like that. So I drove to and from every day. I just didn't say anything. And what I did, I used that opportunity to drive to and from, because in that rotation, you work Monday to Thursday, you work in GP. Friday, you go back to the hospital and you do one day in ED. So I was sort of getting a taste of ED before my actual ED rotation, but I was freaking out because I heard so many things like ED is the one place you can't slip through the cracks. So if you've managed to pass all your other rotations simply because people feel sorry for you and they just want to pass you, ED is where they get you. They're really honest with their feedback. And guess what? They're not fearful of failing people, making them redo the rotation. So I was like, oh my gosh, like this is the test. I have to prove myself in ED, because I may have gotten through like I may have gotten through all those other rotations, but if I'm not good enough, they're going to find me in ED. So I was so nervous. So I used that chance. I was driving 1 hour to the GP, 1 hour back, and I used it to listen to some podcasts on emergency medicine. Now, the podcast I found, you've heard me on Instagram always talking about it, was EM Clerkship. It's actually American, but it is really good. It is really good. It's more teaching you about differentials and little tricks and thinking about like when a case comes to you, because like in medical school, like we learn conditions, don't we? But really in real life, the person doesn't come up to you and like, I've got appendicitis. Yeah. What do you want to do? They're like, oh, don't feel well, I'm nauseated and vomiting, just got stomach pain, so you've got a symptom, and then you've got to work out all these things that belong to that symptom, and then you've got to narrow it down into likely differentials, right? So that's what this podcast was like, and that's what I needed. I needed to retrain the way I learn medicine, the way I think of medicine. So I used that time to do that. So just going back, because I remembered a very valid point, a tip that I wanted to provide. When I was moved in general medicine to, initially was going to be surgery, and then I was moved to respiratory medicine, I just want to tell you that one of my biggest regrets is that I didn't advocate for myself. And this is, most IMGs will understand this who are working. When you are given a job, you feel like you owe these people. You feel like, oh my gosh, like I'll do anything. Like I'm going to, like, you want to work me 7 days a week? I'll work 7 days a week, even though it's illegal. You want to change me, put me here, put me there? I'll do it. I'll do it. Like you don't feel like you can advocate for yourself. And that's the difference between locals and IMGs. Locals, if something's not right, they're going to speak up. Like, nope, I don't want that rotation. You give me that rotation, I'm quitting. Granted, they've got more power to do that because generally they want to keep their locals. So locals know that and they use that as a bargaining chip. With IMGs, not so much, but you can still advocate for yourself. So with that scenario, the admin person who does the rosters and that you email all the time, you always think that they're your boss, but they're actually not. It's just because you don't know the structure of the administration office. Director of clinical training is your boss. Admin is admin. They're sending you rosters, they're sending you pay slips. They're your first line of communication. So when you think that you have to do those rotations, you think you're talking to your boss, but you're not. And a lot of the times, the director of clinical training doesn't even know you've been moved out of the rotation. So I didn't even know that I could say, no, I don't want to be moved. I've just worked in general medicine ward for a few weeks now. I'm still finding my feet. I don't think it's appropriate to move me. Now, had I done that and known who I could have spoken to, so if I wrote that back to the admin person, they would have been saying, and has happened to me before, they'll say, no, but you have to because you're an extra. BS. You're not an extra. You're not an extra. They had a number to fill. You filled that number. Now you are just as worthy as everybody else. You're not an extra. So I wasn't an extra because your local graduate quit and I replaced their spot, not an extra. Okay. You can't just send me here, there, and everywhere. Like you have to nurture my training program as well, just the way you're nurturing everybody else's. So that I would have gotten that back because that does happen. But then I should have escalated it to the director of clinical training. Now, fast forward, me working in the administration office as a medical education registrar, I work directly under the director of clinical training. So I report to them, I speak to them all the time. I'm in the office, I know everything that goes on. And so when IMGs were coming to me saying, Caro, they're about to move me to this rotation. I've only been in, like, for example, I've only been in this department for 3 weeks and they're about to move me to cover somebody else. And I would be like, leave it with me. And I would speak to my boss. The director of clinical training was 100% in agreement that that is not okay to move brand new IMGs who are still learning to find their way. See, they didn't even know about it. And when I told the director of clinical training, they did something about it because it's also not fair on the local. The local who needs that other position covered. So the team that has one spot free that they want to send this brand new IMG to, and that local who genuinely needs somebody to hit the ground running, to know what they're doing, because it's a busy department, especially surgical departments. It's not fair for them to get a brand new IMG because you've just made their life a lot harder. So it's not fair on the IMG and it's not actually fair on the local either. And so when you advocate for yourself, you don't even know that you can and who you can advocate to. I'm telling you now, escalate to the director of clinical training because it's not okay. They need to nurture your internship year as well. Because the other thing is, why aren't they pulling out local grads? Why aren't they pulling out the local grad in the surgical unit and sending them to the other surgical unit for 3 weeks, bringing them back, pulling them out 2 weeks later? Because the local grad would not have it. And they would be like, hold on, I'm trying to learn here. So they know, admin know who they can do this to. They know IMGs don't know the system. They know you will not bite back the way the locals will. So you are the easiest option to do it to. I didn't bite back because I didn't know. I didn't know I could. I didn't know who to. So moving forward, just a tip for anyone starting out, just advocate for yourself. Okay, so then I did GP, and that was really good. Primary healthcare is very interesting because you can't rely on and that was Monday to Friday, and no weekends, and they let you go home at like 4:30. It was really nice. So it was a very, very slow pace, and so it was actually really good. I really recommend that rotation. I loved it. I got a taste of GP world. And you just learn medicine in a different way, and it's really supportive, lots of education staff. Loved it. So then I actually started my ED term. Wow. Was I nervous? I will tell you right now, every day in that rotation, I sometimes had to go to the bathroom. I'd go into the toilet, I'd close the cubicle, and I would literally just like I'd have to control myself. I'd say a little prayer, like, let today be good. And I would say, like, also, Caroline, don't be hard on yourself. If you make a mistake, if you feel stupid, like, it's okay. Just own it and let it go. Don't carry it with you. So that was every day. I'm not going to lie. Most people who have actually worked with me that term in ED will probably have no idea. No idea. But that's what I was doing almost every shift. And so here was my biggest test. Now, I already knew that they had prejudgments because of, like where I did my medical school. They had here we go, another IMG that needs support. So I felt like I was going to be looked at under a microscope. And so I just had to always be a couple steps ahead and really just survive this term, because this is the term. Like I said, they're going to get you. If you're bad, they're going to get you in this term. So basically, what the things you need to know about ED is most people are friendly in ED, but piss off the wrong person, everyone's against you. So sometimes I have like a really crabby nurse at me and like literally nitpicking, and I'm like, Don't do it, Caroline. Don't do it. It's not worth it. Don't bite back. Kill them with kindness because you have to there. You have to. So with ED, I could have prepared a lot better, but you just don't know what you don't know. I'm actually about to start a new role in ED and I'm preparing for it the way now I wish I did, because I've got hindsight, and I'll be sharing that free guide with everybody. So a couple of things you need to know in ED is there's not just doctors that work in ED and nurses. There is another little department in most EDs where you have a nurse practitioner. So a nurse practitioner is a pretty high up nurse who can actually prescribe certain drugs. Um, and they are very highly skilled. And they also maybe work around GP doctors who come into ED and look at more the quick cases, like the GP cases that they can, sort out and leave. Like somebody just needs a quick script. Somebody's got like the back of their earring embedded into their earlobes. Like they're very quick like that. They can just get rid of those cases. I sat with them without knowing where I was sitting because it was just, computer was always free on that side. And so I sat with them and we all got to talking, and I got to talking this one, that one. And remember, my soft skills is my communication, networking. So we got to talking and I made good friends with them. And so whenever I needed like help, guess who I went to? Like, do you have time to show me this back slab? Oh, do you have time for this? Or can I jump with you on this case? I'd love to see your train of thought, how you're doing this. Okay, great. Or can I just ask you some quick advice? I've got this patient, they were so incredibly helpful, incredibly helpful. So I sort of like won because I had the right people with me supporting me without even realizing it. So, and the most important thing with ED as well is just you don't even need to really know what's going on. Just be honest with your consultant, and present really well. Communicate, soft skills come into play in ED as well. Clinical information, medical knowledge, of course. But even if sometimes I'd be like, I've picked up this patient, no idea what's going on with them, but this is my thorough history. This is my thorough physical examination. This is kind of what I'm thinking, these differentials, but none of these quite fit. So I'm just really unsure about what to do next. That's okay, Caroline. Let's see. Okay, maybe we should do this, that. We'll get a bit more information, So like honesty is key. Also, whenever my consultant gave me a job, I wasn't just like, yes, okay. And this is actually true for all my rotations. I was like, all right, to confirm, I'm going to organize a CT head, with contrast, not contrast. Okay. And, all right, and I'll get this done now. Yep, cool. All right, done. Leave it with me. I used to always say that. Done. Leave it with me. Really clear. Good. Done. Leave it with me. I'll get back to you. And I'd always get back to them. They weren't like, where's Caroline? What's she doing with this patient for 4 hours? Where is she? I'd always like update them. It's very hard to track them down in ED, I know. Like they're really busy, but I always tried. So I was literally their middle person. Like, yep, done. Leave it with me. It's that communication that they love. And so here comes time for my mid and end of term report. End of term, the person who looked after junior doctors in ED is one of the scariest doctors I've ever met. She still freaks me out. Yeah, she still intimidates me because she's just like, got a patient? Okay, what is it? Have you done this? You can't read her. You cannot. I'm like, does she hate me? Does she like me? I don't know. Does she love me? I cannot read this woman. So she was going to give me my feedback and I was like, I thought, oh my God. I was like, she called my name. I'm like, here we go. She is brutal. Like, when I say brutal, she's fair, but she's tough. She's got high expectations. She sat down. She's like, very happy with you. I'm like, what? And then she gave me my feedback and I was like, does that, are you looking at the form that says Caroline? I just want to clarify. She's like, yes, I am. I said, wow, okay, thank you so much. Like, and she's like, you're obviously hard on yourself. I'm like, I am, but I also have a lot riding on this. This is why, I am hard on myself. And, she said, no, like, you're really good. My biggest advice to you is just like, what you don't know is what you don't know. And never assume that because you've picked up this case before, like, this patient's presenting like this, it's going to be that. You just don't know an ED. And that's my biggest advice to you, but you're absolutely fine. And they passed me and I was like, what the hell? Because I didn't know with her how she felt about me. And I was like, wow. And I'll tell you what, by the end of ED, that became my favorite rotation because you upskill incredibly quick, incredibly quick. So then I got sent to surgery. And personally, I think having done ED made me really good in surgery because surgery is very unsupported. So in surgery, it's very full on. I initially started in colorectal. Now, remember, I started my internship halfway through a term. So they sent me to colorectal for 3 weeks until the term finished as an extra to help out because the team's really busy. So I was going to do 3 weeks of colorectal. These guys have been in colorectal for 10 weeks at this point. So they much better than me. They know what's going on. And this is a brand new rotation for me. So it's like starting all over again. That's why I say IMGs are not completely comfortable until a year in, until they've done different rotations, because you're just starting again. Like it's like reset, learn again, learn how this system works in surgery, learn again. So every term you got to bring your best shot. So then I go into surgery. These guys look better than me because they've been there for 10 weeks. They know everything that's required of colorectal. So surgery is very intense. Ward rounds, they like to start them between 7 and 7:30. And so you're there a lot earlier doing your patient list. And they move at lightning speed. So literally like a minute ward round each patient. Bam, 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 bam. They're not waiting for the resident to come up with the book and start writing notes. They've already seen the patient when you were like running off to get the folder. So they wait for nobody. So you've got to know that and you've got to be organized. So between your team, your junior doctor team, you guys have to be like a train. Like you've got to have a system. Like, you know, I'm writing notes for this patient. Then they've gone to the next patient. I'm still finishing the notes off. You jump on to the next patient. Now you write the notes and I'll finish this and then I'll jump on. So you're alternating. You've got to be like that. You've got to be like a factory machine. And that's why, like, when you have disconnect in your surgical team, the whole team suffers because everyone is needed. Not anybody's an extra. Everybody hands on is needed. So it's moving so fast, and surgeons are not great communicators. So they're handing out jobs without elaborating. And so that's where a lot of issues come up. So then by like 8 o'clock, the ward round's done. And you do a paper round. Okay, this patient needs this patient needs now. All right, I'm off to surgery. The registrar goes and they're in surgery with a consultant all day. And guess what? The patient that's come out of surgery, met call, code blue, met call, code blue, met call from nurse. This person's hypotensive. This person's got chest pain. So it's post-surgical. These are all crumbly patients. It's like non-stop. And you've got no reg. It's not like medicine. You've got no reg. But the reg wants to know what's going on. So the reg is like in WhatsApp and you're like updating. So they still want to know exactly what's going on in their ward at all times. They want you to follow up on any tests that got done. They want you to chase up any images that got done that day. And you just like, even though they're not there, they're not present, you've got to update them. So it's very, very full on. And so when, for example, where I shined because I had just done ED and this was term 1 of the new interns. So they'd only been a doctor for 10 weeks, but they've been in the department in that unit for 10 weeks. So they had an advantage in that area. But I had an advantage that I just came off ED. So when the nurse was calling that this patient is having post-surgical patient having serious abdominal pain, they had a drain in, I'm like, all right. I went and I worked it up like an ED doctor, where my resident next to me just texted the reg. That is the biggest pet peeve of a reg. A reg is going to be like, don't come to me with a problem. Did you examine the patient? Did you do any tests? Did you like take a history? Like come to me with the story and then I can advise you what to do. And so like I was working up this patient. I was looking at the drains. I was like, checking everything. I looked at the bloods, and then I had my story and I messaged my reg and I told him the story. And then I gave him a couple of differentials that I was thinking about. And I was like, what would you like me to do? So that's the difference. So I was prepared for the chaos. I was prepared for managing a patient because I had just done ED. So that's where I shined in that area as well. And then obviously my communication. But surgery is very full on. So You are left on your own most of the days. There's patients crumbling all around you. Then you've got to do your IV fluids round. So like you go and you like prescribe surgical IV fluids for patients, because Surgeland, they really like um, potassium at 4 and magnesium at 1 at all times. And they like IV electrolytes being prescribed, not oral. So they're really like, did you do this? Did you do that? And, making sure patients have fluids and things like that. So you're doing that. You're chasing every other task under the sun. And surgeons want things now, like now. So when they say go get a med review, they don't want the med review waltzing in 5 hours later. They want it within the morning. So that was the other thing. Like, if any medical issue, whether it's a non-issue, whether it is a big issue, whether it's a small issue, they want a medical review. And so you're constantly calling the medical reg on call that day, and you're like, I need a medical review. So your referrals have to be good. So that also comes down to communication skills, soft skills. You need to know what your specific registrar wants out of that review. That's one of the biggest tips that I've got to say. Like, that was just common sense to me, but it's not common sense to a lot of people because it's not their first job. So for example, when a surgeon was like, this patient needs a med review, I could have assumed what the med review was about, but surgeons aren't very good at communicating. So they won't say they need a med review for their COPD. Now, this patient has like 6 comorbidities. Which one would you like a review for? I can assume it's for the COPD because I can see that's slightly an issue right now, but I don't want to assume, because when you assume and you muck up, the first thing they say is like, why didn't you ask me? Why didn't you ask me? And you're like, well, yeah, I should have. So I'm like, okay, to confirm, what would you like the med reg to review? And what is exactly that you want to know from the review? Okay. I want to know if there's anything we can do regarding medication-wise to optimize their oxygen saturations. Perfect. I'll ask them that. Med regs love that. Like, okay, this is what we specifically want to know. And so this is the disconnect, because surgeons aren't good at telling you that. You're the middleman. You do the referral to the med reg. Med reg isn't happy with the referral, makes you look bad. That delays the review. Your surge reg is unhappy because you've delayed the review. The patient can't get to surgery now. They're upset with you. And you see, like, everything comes back to you. So it's very intense. So your communication is key in surgery. So then they sent me to orthopedics. Another incredibly full-on rotation. Now, when I talk about surgeons, orthopedic surgeons are another level. They're another level. I'm not going to say too many bad things. They're another level. But you know what? One of the best rotations, because it was the most challenging rotation for me in every other way, like communication, everything. It was absolutely challenging, but that's where it really tested my soft skills and really improved it. So I went to orthopedics, same sort of structure. Now, a lot of these surgical rotations, I'm going to let you know, they may have specific meetings attached to them. Like colorectal had a multidisciplinary team meeting every week or every fortnight. So Kate, you would be in charge of preparing the cases. The registrar will tell you what cases you need to get information on. You'd go through the notes, and the registrar would present those cases at the MDT. Orthopedic, they had the X-ray, the fracture meeting, X-ray meeting. I can't remember the name, but basically they would go through all the cases for the last 7 days, like, elective cases and emergency cases. And guess who was responsible for putting the entire PowerPoint together, 150 plus slides? You. And guess who's responsible for like writing the information about the patient as well, taking the slides before the fracture and like after, like pre-surgical and then post-surgical? You were. So like that's on top of all your other jobs that you're doing. So sometimes there's stuff like that. And then you've got pre-op clinic. So you've got to go attend pre-op clinic and, see patients that have elective surgeries coming up, and you basically give them like a pathology form, give them a radiology form, depending on what surgery they're going to have. So you've got that as well. And then you've got outpatient clinic where you might attend and you go and review patients that post-op that have been in the community for however long, and this is their follow-up appointment. And then you present it to the consultant and the registrar who are also there at the clinic. So there's a lot of things you got to do. A lot of things. You're always bam, bam, bam. Like surgery is very intense. Hence why I feel very bad for any IMG that goes to surgery first. But that's where they need people. So they send people where they need you. So that's where I ended up. Orthopedic. But I loved orthopedics. Let me tell you, had I done orthopedics and then went to ED, because you're always referring to orthopedic surgeons in ED, obviously fractures come through there. My referrals would have been a lot better. Like now I know exactly, what they want to hear, how to present to them. So that would have helped. But still, it was a fantastic rotation. You suffer, but you learn a lot. So that's my takeaway line. So that was my entire internship. I passed everything, mid and end of term assessments. So I already satisfied the 47 weeks of supervised practice. And all that was left of me to do was some form of clinical exam. And I chose to do the WBA program. So as long as I passed the WBA program, I was all set to get my general registration, which I did. So now let's talk about the social aspect of being my internship. So I told you about the nitty-gritty of the terms and the rotations, but socially it's very difficult because the interns are mostly all went to the same medical school. They've trained at that hospital. So they have their own little clique group and you are like on the outside. And so when they don't know something, they just message each other. They're in a little group chat and they all tell each other the answer. Like, also when they're like going to one rotation that another local intern was already on, they do a good handover with one another. They give them all the details, like message me if you have any issues. So they've got that extra support and you're on the outside of that. So there's that issue. And also like, I guess some are willing to help, some are not. Some are frustrated, some are not frustrated. Some are really kind, some are not kind. This is just the nature of working with anybody in large numbers, isn't it? So with me, I felt very much on the outside. Where things started to change was when I started becoming friends with registrars because our age is closer. So I felt like more relatable to them. And so I became really good friends with the registrars, which meant like, when they were like, oh, we're going to go for coffee. Do you want to come? We're going to go to the pub that was across the road from the hospital for after work drinks. You want to come? And I was like, yep. Even sometimes when I didn't want to go, I was like, yep. Because I've moved around enough times on my own where I've learned like when you're a new person in a new place, say yes. Say yes. Even if you don't feel like it, say yes, because networking is extremely important part of your success in the workplace, but also your mental health. And I wanted to make friends. So I was like, yep. And some of these guys are like the closest friends I've got and like literally will be my lifelong friends, like hands down. So it was such a great opportunity to meet amazing people. And I did. So that's when things started to change for me because also when I was friends with the registrars, when I had to do a medical review in surgery, I was calling a friend, wasn't I? And they're more likely to help you when you're their friend, So that's how I sort of kind of started feeling like not an outsider, but very much on the in. So, and then the downside, so from the social aspect, is that you are dealing with very young people as colleagues. So interns are usually 23. If this is their first degree, it's usually their first job. So you're dealing with emotionally immature people. Even if they're quite mature for their age, they've still got that low EQ. And this is absolutely no judgment. I am saying this as somebody when I put myself back when I was 23 in the workplace, I could have done things so much better, like communication wise, attitude, dealing with difficult people. I could have done things so much better, but that's what life experience is for. That's how you grow your EQ. So that is the downside. You feel like you're just being pushed back into high school again. And like for me, that was just, it almost felt suffocating at some points, like that I have to deal with this pettiness, like you've got a problem with me, but you won't say it. You'll just come in and like slam things and like at the computer. Like I had that. And I'm like, come on, man, I can't do this. I cannot do this with you. I'm way too old for this stuff. So that is the downside. Like instead of communicating frustration or communicating an issue, they wouldn't. And also you've got the other side where people are very competitive. Like they've just come out of high school was competitive, uni's competitive, and they're still in that competitive mode. And guess what? They're deliberately not going to tell you information so they can always look the best to the registrar in the team. You do come across those ones. And so there's that issue. There's being like people not providing information so they can always look the best. And that's pretty crap. So that's the downside as well from that aspect. So it can feel very isolating, especially if you're an IMG intern, because there's not many of you. If in fact you may be the only one in the internship cohort that is an IMG. Yes, you'll have IMG, PGY2, PGY3 junior doctors, but they're not in the internship with you. So it can feel very isolating. So saying that, I'm going to switch to the questions that were sent through the Instagram and Facebook. And sorry, this is an extremely long live, but if you know me, I like to give full details because I think it's really important to be very transparent so people know what they're getting themselves into. Okay, so let's go into this. If I got this question a lot, if someone has already done an internship back home, can he or she apply for the internship in Australia? Technically, you can, but I was very confused this question. Why would you? If you've already done an internship back home, why would you want to apply for internship in Australia? Because remember, unless you haven't watched my internship podcast part 1, remember there's not many internship positions for international medical graduates. In fact, there's like no position designed for international medical graduates for internships. It's all locals and international students who studied in Australia. It's only when they pull out can you have one. So why would you do that when you can apply for a PGY2, so postgraduate year 2 level junior doctor position? There's more of them. So if your chances of getting an internship is really low, why wouldn't you go for something that is a lot higher? So yeah, you can, but I feel like you're just setting yourself up to fail, to be honest. There is a slight exception. And I recorded this podcast with this amazing, amazing international medical doctor yesterday who went backwards and did an internship in Australia, even though she had an internship back home. But it is a rare exception. And that's why I don't like to advertise it too much, because it's circumstantial and it's up to the hospital's discretion to do that. And for her, they wanted to do that because her partner was working in that hospital. They loved her partner and they wanted to keep, and they liked her as well. And because she did an observership program and they were very happy with her. So they wanted to keep them. And so when an internship position came available, she waited a year. She waited a year after her observership program because they didn't have one for her. And when it became available, they gave it to her, even though she already did her internship. The reason being is that she had a clinical gap of 8 years, no recency of practice. So you can go back and get an internship because basically that's like starting all over again to APRA. But a hospital kind of like, it's not bending the rules. It's a little bit of a loophole, but they kind of like, it's up to their discretion if they have an internship available and you've already done one, but you've got a massive, massive gap and they want you in their hospital, they'll provide it, they'll offer it to you. So that's, again, not very common. And that's why I don't like to overly advertise that, because I want you to make good decisions for you and your family based on probability, and not like the 1% times this has happened. Okay. So how long does it take to get a job after AMC 1? How long is a piece of string? For some people, many, many years. For other people, 2 years. For other people, 1 year. It just depends on how good it depends on strategy and it depends on luck a little bit, but also some people's CVs, and I'm not talking about their level of expertise in the CVs. I'm not talking about that they haven't done enough research papers, they haven't done a master's, but their CV just looks poor. like the formatting, the way it looks, and that really says something. So, presentation's key. Your CV is your first impression. So it just depends. It really depends. For some people, it's a massive, long journey. For others, pretty easy. I think the key thing is your recency of practice as well. If you're like recency of practice, the last time you worked as a medical doctor was a year ago, a year and a half ago, you got a high chance. So that, like, versus if you're 5 or 8 years, they're probably going to push you to the side and look at other applicants. So I'm from Indonesia and I finished an internship in Indonesia. So if I pass AMC exam, what next? What next is your English exam, and then you can apply for jobs. And if you don't know what next, you really need to listen to our Moving Your Medical Career series. It's a playlist on YouTube. I literally tell you all the steps in the different videos and everything you need to know about those steps and any issues. So please, if you're serious about coming to Australia and working here, this is what we've developed is honestly a rare opportunity. It's insight into the whole process and our experience and everything we didn't know. We learned the hard way. We made the mistakes, but luckily we didn't like lose our registration, or we didn't fail end of term assessments. Like, we were naive, but we managed to get through, and now we're completely aware. So you have so much inside information being provided to you, so you don't have to be blind to this whole process like we were, or be naive. So really, you need to watch that. Is there any age limit to apply in the gap in practice? No age limit to apply. I know people that are 60 years old doing internships. But gap in practice for internships, it's not really a gap in practice, because in the internship in Australia is done differently to overseas. You do medical school, and you don't do an internship in medical school. You graduate instead. You graduate as a doctor, and you work. It's called PGY1, postgraduate year one. You work as an intern, and you're actually a medical doctor. You're registered, and you get paid by the hospital. So it's actually a job. It's a position. So when you are applying for an internship, it's under the assumption you have no recency of practice. You've never worked as a doctor, because that's what interns are here. They've never worked as doctors. So you don't really need a recency of practice. But like I said, if you have done an internship and your recency of practice is 3 years, if you're struggling to find a job for a resident PGY2 level, then you're probably going to find it harder to even get an internship, because there's much less of those. So just factor that in. You might need to go home, work 3 months full time, and then that will boost up your recency of practice, and then you're more desirable on paper for those PGY2 plus jobs. Okay. And also, if you can't do 3 months straight, because I understand people have families, you can do 1 month straight, come back for a bit of a break, go back another month. So just try. It's like, fill it up. Is it manageable to study AMC clinical while on an internship? Now, I think I talk about this in the WBA podcast on our Moving Your Medical Career series to Australia. You've got me and Sasha talking about our WBA experience, and then you've got Sasha and Brendan. Brendan is an IMG who chose to do the AMC2 exam. It's a preference, and what I would say is really know your strengths and make a decision. My strength is not juggling my internship and even full-time work and then going home and studying. I've never been able to do that, ever. I know that about me. I am not that smart, people. I'm not that. I don't have like a photographic memory. I can't. And also, like, I get exhausted really easily. I can't get home and like, let's study for 3 hours and let's remember. I will read something last week and I'll completely forget it this week. That's why I had to write these notes, guys. I had to write notes on my internship because I was like, what? My memory is so bad. So I knew, for me, that is not an option. So choose what works for you. Know your strengths, and don't listen to what other people say. Oh, no, do AMC2. It's a lot quicker. It is a lot quicker. But what if you fail it? And what if you fail it again? I know people that have failed it 3 times and now they're doing WBA. So people that started before me, who I've gotten general registration before them. So it doesn't matter what anybody tells you. Do what you think you can achieve, and stop listening to people all the time. Like, do what you think you can achieve. Okay. How to target WBA program? I'm not sure if you mean like how to actually study for a WBA program. It's not really related to internship, but what I would say is listen to the WBA program podcast. Okay, most positions open on May to June with a slight difference because of different states. Right now, how to prepare. Okay, so your CV is your CV and a cover letter. If you can upload a cover letter, your CV is really important. It's your first impression. Now, there's somebody that jumped on to this live whose CV I personally went through, and when I was working at this hospital, and like I even write notes about people's CV, and you know what I wrote? I wrote lovely CV, really straight to the point, easy to read, well formatted. I'm interested in this candidate. And then I met them and they delivered that in person as well. So I was like, hands down, I told my boss, you need to give them a job if you're looking for doctors, because this was an observership interview. So I say, if you're looking for doctors, you need to consider this guy I just gave it away. Consider this person for an interview, and they did, and that person got a job. So like that's your first impression. So just make sure like it's good. It's good. And just so you know, like Sasha and I are working on a CV and cover letter course, and we're hoping that'll be the first thing we deliver in like within 2 to 3 months. Because yes, there are other courses out there. I don't know if I can recommend any of them because I personally haven't done it. But what I can say is that where I hold a unique spot in this IMG space is that most IMGs will get their general registration and they'll leave the hospital or they'll go onto a training program. Very few have ever managed to get into the clinical support unit administration side. So now that I have been on that side and I've been doing interviews and I've been looking at CVs and I've been creating resources for IMGs in that hospital, I now know exactly the politics of like the director of clinical training, what they need to satisfy, like what they need to look for, what level 1 of supervision means for the hospital, what level 2 supervision means. And I know exactly now how to deliver a CV that I actually changed my CV very recently before I was applying for this new job. Because now that I know what exactly they're looking for, I went ahead and delivered my CV to deliver that information really, really quickly, and look professional. So, because you got to understand, they're looking at like, I went through 80 CVs at one point. So they're looking at so many CVs. So if I'm going through like 6 pages and trying to work out like how many years of clinical experience do you have, or when did you have this clinical gap, and what, like I'm trying to work things out. It's time consuming. So sometimes when you're getting through towards the end of those 80 CVs, you know, you might not be as on the ball as what you were when you started. So you got to understand these admin people, they're not just looking at you. They've been at this all day and you've got to deliver the information quickly. The same way with your interviews. So these are little tips I have to give you, but that's why I thought like it's so important now with this information I've got and this experience that I go ahead and create something for you guys, because everything else that's out there, these people haven't worked in the IMG space. They haven't worked in the admin hospitals, and there's actually only one person that I've seen their stuff and I'd be like, yeah, actually I would pay for their course. But many others, I don't like, no, they haven't been junior doctors in a very long time. They haven't worked in the hospital a very long time. They've never worked in the hiring section of the hospital. So like to me, again, we've got this unique opportunity to provide proper information to IMGs. And if you're going to pay for something, like at least pay for something that's worth it. Okay. Okay. What's the next question? I had quite a few questions come through. For an IMG, which things or tips in the CV that make him or her more competitive to get a job? Also not internship related, but I'll answer it just really quickly. Like I said, it's not about how much experience and what masters you did and this and that. It's really comes down to your recency of practice. That's what the biggest thing that they're looking for, because that needs to satisfy APRA. And so like, even if they like you, if you haven't got recency of practice, they know if they hire you, you're probably going to get knocked back from APRA and you're going to waste everybody's time. So recency of practice is a big thing, but just be mindful how you're presenting on your CV. Okay. The words you're using, the formatting. Like I've opened up CVs and I'm like, how did you think this was a good idea to send this? Like it was, I never appreciated it when I was working as a junior doctor and not in the admin side. I had no idea just how bad um, CVs were. And because locals, they've grown up doing this their whole life. So their CVs are beautiful. And so it's such, that they're so used to looking at those kind of CVs, and then they get the IMG CVs. So you got to understand, like, it's just the little things that make such a massive difference that say a lot about you. So treat it like your first impression. Okay. Is internship necessary for AMC Part 2 and general registration? No. If you've already done an internship, you don't need to do it in Australia to get your general registration. To get your general registration, you need 47 weeks of supervised practice, and you in 10 weeks of medicine, surgery, 8 weeks of ED, and you need some form of clinical exam. So AMC Part 2 or the WBA program. If you're unsure, you really need to listen to the Moving Your Medical Career series on our YouTube. And that's part 5. Part 5, we talk about everything you need to get your general registration. Okay, does PGY1s and PGY2 interns work as medical officers? Okay, so I might have to do a post on this on the like a hierarchy. So we've got junior doctors here. This is the title. What makes a junior doctor? PGY1. So this is medical school. I graduated. I'm now officially a doctor. But you go into PGY1, you're an intern. PGY2, you're a resident, or in some other states, they call them junior medical officers, resident medical officers, junior house officers. So that's how it works. PGY3, you're still a resident. PGY4, you may be considered as a senior resident medical officer, a senior house officer, or a senior junior doctor. So that's how it works. So PGY2 is not an intern. Okay. Will my house job experience be counted in Australia for PGY1? So I think they're saying, will my internship be counted? It just depends. So most of the time, yes. But like I know of somebody who received an offer for a PGY2 junior doctor role, because they did an internship overseas. Then when they went through the APRA registration, APRA said, we don't recognize your internship. I'm sorry. It doesn't satisfy what we consider an internship. So the hospital could no longer let her have this position because technically she hasn't done the requirements for a resident role because her internship is invalid. So at that point they had no internships available, so they couldn't give her a job. And so at that point she had even moved down. She had moved down, and so she had to move back, and she trialed looking for an internship elsewhere, and took a while. Like I think 2 years later, she got something. So it depends on your internship. What I will say is know what an Australian internship is. It's at least 10 weeks of medicine, at least 10 weeks of surgery, and at least 8 weeks of emergency medicine. But overall, it's 47 weeks full time. Full time, can't do part time. So if your internship back home sounds like you've satisfied that, then I think you're okay. I think you'll be fine. If your internship doesn't sound like that, probably not okay. So what you probably should do, it's a hard one because it's up to APRA really, but like at least get some 10 weeks of medicine, get some 10 weeks of surgery, get some 8 weeks of emergency medicine, even as a resident. That's what I would say. Okay, this is actually pretty amazing. A local graduate doctor has sent through some messages. So I just want to say, like, Code U Australia is right now heavily focused on international medical graduates because that's what we are, and that's where the deficit is to provide this information. But we do want to cater to junior doctors, especially with our Sasha and I are going to do a soft skills masterclass, a free one on likely YouTube. So that caters to local grads. And this is a masterclass that we actually provided at the hospital we used to work for all the local graduates. So because we notice like that's the biggest feedback we get from senior doctors is that they're not good communicators, they're not good they don't refer very well. This is for locals, not just for international medical graduates. That's the feedback we were getting for both. So we gave this masterclass, and Sasha and I thought we'll revamp it, and we're going to do it for you guys. So it's amazing that we actually have some local graduates that are on Code U. And so these are great questions. Okay. They asked me, what did you find the hardest about your internship as an IMG, and how do you remedy that? So there was lots of things that were super, super hard. And it just depends on the rotation. I think what I found hard, like overall, was like I said earlier, you do one rotation and you manage to like finally find your feet, and the rotation's over and you go to surgery and it's like brand new again. Finally find your feet, and then bam, you're again. And that's I found very difficult. And I found the culture, like I found that hard. So the locals sort of like not being patient, or the locals looking down on you. That's how I felt, and that's what I found difficult. So yeah, I felt like that was pretty hard. The other stuff wasn't so bad because, like I said, communication was probably a big trait of mine. So I just used it to my advantage. I didn't have to relearn that. And I didn't even realize like how much I shined compared to others in that area until I like realized, oh, okay, because you're dealing with people that haven't worked before. So you're naturally going to have that skill and shine there. So that was okay. So it was really just the culture, and like every new rotation was like anxiety felt like, okay, I've got to prove myself in this rotation. I've got to deliver. So it was a lot of pressure. How did you improve the bad and ugly bits when you recognize them? Okay, so let's talk about one ugly bit. One ugly bit is the attitude, like from the locals. So, like for example, I told you when I had to move to surgery, like the locals were talking and they got all dramatic, and like they even spoke to me in the doctor's room, and so made me feel uncomfortable about that. When that would happen to me again, how I changed that, I'm going to say it very, very blunt. I don't take shit. And that's why I say to all the IMGs that start, that worked in the hospital, I said, do not take shit. And I'll tell you why. When you don't stand up for yourself, you're letting other people write your story for you. And I'll give you an example. When you're working with locals and they get really close to the registrars, because the registrars are usually locals as well, and they relate and stuff to each other. So when you like it's just a natural thing, it's no judgment. But when they get close to the registrar, whatever they say, the registrar will believe most of the time. So if you feel like your local is like setting you up to fail, or they're being difficult, and you don't stand up for yourself, they like automatically will, when they'll tell the registrar, oh, they're hopeless. They're hopeless. Oh, the other day they did this and blah, blah, blah. And they tell their version of the story. And you're trying to not be a troublemaker. So you're like not saying anything, not knowing that the story has already been said and told for you. And now this person has a different narrative about what happened. So what I realized, and what happened to me when I went to surgery as well, is when I asked a question and they deliberately did not provide me the information, and I went to go do the patient list, and luckily I had spoken to somebody that previously worked at the hospital that said, oh, you better get in there early because you got to do the master list. And I was like, what's a master list? Basically, I was set up to fail and look bad, and that would have slowed everything down. And so when I found out that they deliberately didn't tell me, I was fuming. And I wasn't going to be the quiet IMG putting up with it. And I'm like, nah. You know why? Because not only would you have made me look bad, but you would have delayed the ward round. That's not okay for anybody, just because you're a competitive, immature person. So I was like, I told them, I basically wrote in a message, I said, when I ask a question, I expect an honest answer. And you got to understand, locals don't expect IMGs to stand up for themselves. There is this generational thing in the hospital that they're used to, like IMGs not standing up for themselves. So I'll give you an example. Like when one of them screws up, very little doesn't really spread in the hospital. Reason being is that they might be talked about within their little groups, but they know it could potentially get back to their local colleague because they went to uni with them and stuff like that. So they know like it can get back to them, and they don't want that. With IMGs, they know you're isolated. They know, like, is it even going to get back to you? And if it does, what are you going to do about it? Are you going to confront me? So they're not used to being confronted. So when you come in with your big girl boots and you confront, and I'm not saying in an aggressive way, in a professional manner, when you confront and you want to discuss what's just happened, they're a bit shocked because you got to think about when you were 23. Could you put your money where your mouth was when you were 23? Could you run your mouth and have somebody confront you and you go, "Yeah, well, I did do that. Yep, I did do that because that's how I feel about you. I don't think you're a good doctor. I don't like you." Like you could never do that. You'd be like, "No, I didn't say it like that, and I didn't mean it like that." That's what you're dealing with. So I just realized, like halfway through, no, we're not going to do this. I'm not putting up with this. And so things change. Things change. If you were going to play me, you were going to get confronted. And so that's the biggest thing I recommend with all my IMGs is like the moment you cop it, you will keep copying it. And don't think for a second you're not ruffling any feathers and you're not making a bad name for yourself because other people are going to make a bad name for you. You got to remember the hospital is like the environment's like this, unfortunately. I hope it changes. I think we are going to change in the future with more better like understanding of bullying and things like that. But this is how it is for now. So you've got to like nip it in. Okay, so that's how I dealt with that. And obviously, the feeling like I'm looking at being under a microscope and being, judged and like more harshly than locals is just always being a couple steps ahead. I just had to. That's just how it is, and you just got to have strategies and you've got to deal with it, and you got to be a couple steps ahead. So that's how I dealt with those things. Um, this is a great question. What can local grads do to help IMGs without feeling like we are being condescending? This is a brilliant question. And it reminds me of orientation week for the interns. I presented I did a presentation for them. And this was my advice to them. And it answers this question. Okay. Local graduates. I need you to do, I've got 5 things here. I wrote it down because I want to say this correctly. Change your mindset, invest in your IMG, work with everybody's assets, communicate with each other first, and remember your inability to work with different people from different experiences, from different backgrounds, is more of a reflection on you. So you actually end up just looking bad in the workplace when you're running to the director of clinical training complaining because this is real life, especially in a hospital where we have so many staff members. And especially where in hospital we change our team every term. So unlike my husband, who's in corporate finance, who has the same team all year round, unless someone resigns and they hire somebody, it's the same team all year round. We change every term, new consultant, new registrar, new junior doctor colleagues. So your inability to work with each of those people every single time, different people, is more of a reflection on your EQ. So it's not a good look. So what I mean by those things, change your mindset. What I mean is you get frustrated like, oh, this IMG doesn't know what they're doing. They don't mean medicine. They mean you don't know where the referral forms. You don't know how to refer. You don't know how to organize outpatient clinic. That's true. These are all true points. But I say to locals in this presentation that, guess what? You were medical students in this hospital. If when you do choose to leave this hospital and go to a different hospital, you're the new guy. And guess what? They don't do orientation. They don't show you every form under the sun. They don't show you everything here and there so you're ready to go for no matter what is asked of you. You're the new guy. And I gave this example to one of the local grads who had moved hospitals. 2 weeks in, this person rang me crying. It's so hard. Like people are frustrated with me because I'm slow. This is a local grad, but no one showed me how to do things. No one showed me where these forms are. No one showed me this. And I said, okay, but this is what IMGs go through. This is what I'm saying. It's not you're comfortable because you were students in this hospital, but that comfortability will not last forever when you move hospitals, and then you'll understand what an IMG feels. So it's not that they're stupid and they don't know where this form is. It's the fact that it's a brand new workplace. And when you go to a brand new workplace, you'll be in the exact same position. So be kind because karma She come back around. Okay, guys, she comes back around. I truly believe that. So change your mindset. Second one is invest. Invest in your IMGs. So I always used to say to them, if you don't show this IMG around, if you don't show them where these forms are, so this is a say, for example, a three junior doctor team. When you don't show that third doctor, the IMG, how to do things, you're essentially you're choosing to run this unit on two junior doctors. That's your choice. And you're going to do that for 13 weeks. And I promise you, 4 weeks in, you're going to come running to the clinical support unit burnt out. But that's your choice. You did that to you. So you need to invest. Yes, you got a shadow with you for 4 weeks, asking this, asking that. Oh, it's driving you crazy. But remember, you're going to be the new guy one day somewhere else. So invest in your IMG, show them everything. Do not withhold information, because around the 4-week mark, they're going to be a lot more independent. And now you can truly start delegating them things. And your team no longer is like running off the back of 2 junior doctors, but more like 3 functional junior doctors. Okay. So I say that invest. It's short-term investment, long-term gain. Okay, work with your assets. So when I went to orthopedics, this was at the end of my internship, so I've been there almost 9-10 months. They gave me a brand new local graduate that didn't study in that hospital. They were from another state. So this was the first time they were doing ward work. And they gave me Dr. Faraz, who's going to be on a podcast, IMG Success Stories, Dr. Faraz. So he basically only did a few weeks of stroke, went to do nights, and then came to surgery, orthopedics. And it's an intense rotation to send any newish IMG to, or any new doctor, really. So here you had 3 junior doctors, but really we were functioning at probably like 1.5, if that. So I had brand new local grad from a different state, doesn't know how this hospital operates, doesn't know what departments we have, doesn't know what these referral forms look like, doesn't know anything. And this is an intense rotation. Things move very quickly. So what was I going to do? I'm not going to be like, I want to look the best and I'm going to make myself shine by making them look as bad as they are right now. No way. So I invested. I worked hard with them. I showed them everything. Sometimes I was in clinic and I wasn't even on the wards that week. And one of them would message through to our chat and saying, hey, like, I need to do this form, or does anyone know how to do it? And I would say, yep, I'm coming up. I used to leave clinic, come up and show him how to do the form and go back down to clinic. Or like saying, oh, I'm a bit swamped. I'm not sure. Like I've got so many things on. I'll come up and help you. So I invested. And by far to this day, that is the best team I've ever worked in. And we bonded, we laugh on our podcast, we bonded through trauma of being on orthopedics, but it was the best team because we worked so hard and we worked so hard for each other and we built each other up that literally we were such a solid unit by the end of it. And any issue that came up, we were like, boom, 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 we could work together. The burden wasn't just on one person. So least experienced team, by far the best working team I have worked on. So invest, really important, and work with your assets. So going back to that point, work with your assets. Dr. Faraz clinically was better than me, like medical knowledge, better than me. But I had experience in this hospital, the communication side, the forms, this and that. So when we were left on the ward on our own, and orthopedics, there's like a code every freaking day, sometimes 3 codes happening at the same time. We worked in our strengths. So when I wasn't sure medically, it's like clinic knowledge wise, I would just pass an idea to Faraz. And Faraz is like, oh yeah, no, we could do that, or we could do this, or let's call the medical registrar. Like we would sometimes call our medical registrar instead and like get some advice. So we worked to our strengths. And that was really important. So he taught me so much. I taught him so much. And that's what I got to say to locals. Don't look at the forms. Think about that stuff. Understand that these guys, IMGs, are coming in with such amazing clinical experience because they work in countries where you can't just scan something and, yep, scan, it's fine. Like you have to use textbook knowledge. You have to use your clinical examination skills. So They're coming in with so much knowledge. Utilize that knowledge, utilize that experience. While, you can use them for that, they can use you for showing them the forms and this and that. So everyone is playing to their strengths. So the team is running at the best it can. So extremely important. Communicate with each other first. What I mean by that is if you're frustrated, please don't go running to the clinical support unit. You have to understand these guys have sacrificed so much to get their foot through the door. Your frustration, your inability to communicate, not everyone, I'm just generalizing here, your frustration, inability to communicate conflict and conflict resolution with your colleague um, shouldn't mean that you run to the clinical support unit and you damage the reputation of this IMG. Also, you guys may have a misunderstanding. Why don't you communicate with each other first? See if you can deal with the issue in-house first before you run to the clinical support unit. So having a bit of empathy and understanding, like, that what you're doing to the mental health of this IMG, who will find out that you ran to the clinical support unit and you think they're crap, what you're doing to their mental health. It's a horrible feeling to walk into a room and feel like your colleague does not like you. So please don't do that and communicate with them. Um, and overall, like I said, it's actually just a bad look on you. Your inability to communicate with your colleague is a bad look on you. If you're just running to the clinical support unit, the moment things get tough, it's almost like running to your parent when you're upset with your sibling. Like, we're not doing that. We're in the workplace now. There's emotional there's emotional EQ, emotional intelligence. That's really important to have. So it's actually just makes you look bad. So please communicate with each other first. And this is life. Life, you don't get to choose who you have to work with sometimes. You need to be resilient. You need to work on your communication skills. I thought I had this down pat, and then I worked with somebody. I'm gonna blame you. Why my child is an angry little toddler. I blame you. I was always angry. I was always frustrated at the start. I was like, what is wrong here? And really tested my conflict resolution, my communication skills until I just had to sit this person down. I'm like, we got to have a breakthrough moment here. We need like family counseling. We need a breakthrough moment. We had that breakthrough moment, and it taught me a massive lesson that like, this person was harboring a lot of basically bad experience in the hospital, and they were just literally in fight mode all the time, and they were just so worried that they were going to be taken down at any minute, and like, their career was at jeopardy. So they thought, here's another person's going to do that to me, potentially do that to me. So when I had to sit them down, I was like, I'm not going to do that to you. But you have to be honest with me. You can't play these games. Like, if you can't do something, tell me you can't do it. I'll show you how to do it. Like, I'm not here to ruin your life. I'm like, I just want to I don't want to be bluffed. I don't want to be all these excuses you're throwing at me. Just be honest with me. Caroline, I don't know how to do this. Can you show me? Good. Let's go. I'll show you. So once we got through that, I liked working with him. He was great. But so you got to understand, like, people always test your conflict resolution skills, and it's really good to have that. You need these challenges to grow that EQ. Okay, so really, really important. Okay, so I'm just going to see if there's any more questions in the Q&A, and then I'll look at the questions that came up in the chat. Can we do internship in Australia if we have foreign graduates, and will it be easier? So I already answered that question, and watch the podcast, internship podcast part 1. There's not many positions that ever become available, so it is not easier. My biggest recommendation, if you are overseas and you are still able to work, please complete your internship there. Do that. And even if you're overseas and studying for your AMC 1, can you at least work part-time, like 2 days a week, or even 1 day a week? 1 day a week counts as a recency of practice. So just hang on. If you've got an opportunity to keep working and hang on to that recency of practice, please do it. It will serve in your favor. Is the same as the core rotations needed for general registration? Yes, it is. You don't have to ask for it. They're just given to you. Um, what things did you add in your CV for a successful internship post? Honestly, my CV was pretty basic because when I was applying for internship, I had no recency of practice because I'm applying for internship. Um, like there's no word of a lie that being an Australian citizen and being in the country worked in my favor. So I'm not going to play dumb to that. Um, if you're so when I say this in the internship podcast part one, for last minute internship positions, they're not going to take someone from overseas. Like when I mean overseas, it's still living in overseas because it's a last minute position. They need someone ASAP. So they don't want to deal with the visas and all that. So they're going to take people that are in the country ready to go. And it's going to be similar even if you apply through the campaign. Yes, you've got more of a chance, but it's still a very, very low chance because while you apply through the campaign, there's a ton of people in Australia that need internships, IMGs that need internships that apply through that campaign as well. And who do you think they're going to take? They're going to take the one that don't have to deal with a visa that they know for sure can go on this start date and they just need upper registration process. So please do yourself a favor if you have a choice. I mean, I never want to discourage anyone, never say never. Apply for both ways, but I'm telling you now, like your chances of getting an internship in Australia not that high, especially if you're overseas. So just do your internship over there if you can. um do things like referees, observerships, or Australian experience needed for an internship? No, not Australian experience because if you're an intern, they assume you have no recency of practice. Observerships can, but I want to make this really important point. Some observerships you pay money for, and you get an interview at the end if a job becomes available. Now, if you're waiting for an internship job to become available, the chances of that is a lot less. So you might be paying for an observership that leads you nowhere because even if they like you, even if you did well in your interview, if they got no internship, you can't have one. And that's what happened to one of our observers. And that's what happened to Dr. Maria, the IMG Success podcast that I filmed yesterday. So she waited a year and then something came up at that hospital. But they still remembered her because her partner works at that hospital. So chances with you, would they remember you after a year? I don't know. Maybe not. So I would say observerships, not 100% necessary. I just don't like IMGs wasting their money. So I'm really big on with observerships being very transparent. I did find out that, and I'm going to do a post when I contact the hospital with more information, that there's quite a few free observerships in WA, free. And 2 are at a hospital that always hire their observers because they really need IMG doctors. So I'm going to contact the hospital, get more info, and then I'm going to do a post on it. So just to let you know. Okay. My younger sister currently pursuing her 4th year. What were the options for internship for her? So I've kind of answered it in this whole podcast. A lot lower. So please do your internship back home first. Okay. Just want to make sure I don't miss any. Oh, okay. If we apply for an internship through Queensland, will that make us eligible in all of Australia? Okay, so this is how it works. When you apply through Queensland, only the Queensland health hospitals are going to look at it. New South Wales doesn't access Queensland's database. WA doesn't access Queensland's database. What it does is when you go to apply for a last minute internship position, and I'll use my example. When I did that phone call and said, I heard that, I didn't say, I just asked, do you have an internship position available? Because my friend told me that they did. And they said, we do, but have you applied somewhere else in the country? And I said, yeah, I applied through the Queensland Health Campaign. They're like, good. Because technically I'd applied somewhere that legally they could tick that off, that I've been in the campaign somewhere. So it's not that they access the Queensland Health Campaign database. They don't. It's just like a formality thing. So just so you know, when you apply for Queensland, you're only applying for Queensland. But if you want something in New South Wales, I don't know if the New South Wales campaign allows for IMGs to apply for internships. I would say just look at all of them, but even if they don't, if a last minute position becomes available and they've got no locals to give it to, they've got no international students to give it to, and you send them your CV, they're legally allowed to hire you, so it's fine. So even if that you weren't allowed to apply through the New South Wales Health Campaign, okay, because they just need the spot filled. So don't listen to people, because that's what I heard. Like, no, there's no way you can get one in Victoria. There's no way you can get one in Northern Territory. There's no way you can get one here, there. I was just hearing like nonstop. Queensland's the only place you can go. That's it. But that's not how it works. You just hear these stories from other IMGs who've heard stories from other IMGs. So that's not how it works. What were the clinical books that help you during your internship days? Okay, I've got it here. I'm going to show it to you because it's not just for your internship. Marshall and Rudy's On-Call Principles and Protocols. Okay. It has emergency calls. It has common calls, so common ward calls, and it even has practical procedures. Please get your hands on this book. It's at bookstores in Australia. It's on Amazon. It has a digital copy if you like a digital copy, or if you like me and I like a textbook. You know why? Get your hands on it now, even before you start working. These common ward calls are legit. They are actually the common ward calls that you get in the hospital. These come up in interviews. And if you've read this, and I wish I knew this, I did not know this. When I got the job, I was like, I wonder if there's like a handbook, like a pocket guide or something I can hang on to and have in my bag to help me, especially on weekend shifts when you're covering more units. And I found this, and when I was going through, I was like, man, I wish I had this for my interview, because this is literally gives you the structured approach to answer a question like, okay, you've got a patient here with abdominal pain, you're visiting them post-surgical. What do you want to do? What's your approach? It's all in here. Same weakness and dizziness, syncope, so headache, like get your hands on this book. Okay. If you want to do well in your interview in the clinical section, if you want to do well on the wards, start reading it from now. Really good. So that's the book I highly recommend. There's other resources to use while you're working, because this is a bit like clunky to carry around. But to start you off, this is the book. If we are doing our internship in the motherland, then what are the prerequisites to apply for a PGY2 role? So AMC1 at least, and an English exam, recency of practice. Keep working if you're still overseas, even if it's 1 day a week. Can't stress that enough. Any chance of getting an internship directly after graduation in a 6-year program? I kind of answered it before. If you're still overseas, pretty unlikely. Never say never, but low chances for the reasons I explained earlier. How much independent patient care is expected from an intern in Australia? More on surgery. Yeah. Every other one, no. On surgery, yes. But remember, they don't expect you to make big decisions. So if you can't get a hold of your surgeons, you need to escalate, like I did in that previous example I gave you. So just know what level you're working at and don't do anything above, because if it doesn't work out, it comes to bite you badly. And that's the first thing your clinical director will say is like, why'd you do that? That's not your level. So knowing inside your level and knowing where to stop is extremely, extremely important. Okay, we've done those questions. Now I'm just going to scan through here. Okay. Is it possible to get a job with experience internship only. So it's 1.5. So I did an internship and now 1.5 year gap. So applying for an internship would be a good idea, or a JMO position. I think a JMO position, 1.5 years gap is pretty good. Like it's actually pretty good from what I've seen on CVs. So internship positions, there's not many. So you might as well go for one that you're eligible to apply for, which is a JMO position. That's what I would be doing. Um, the other thing that would be good for you is if you could also, if you found it hard to still get a job, do an observership with that 1.5 year gap, because you're kind of like ticking all the boxes. Like, oh, you've done observership in the hospital, you've got a little clinical gap, so like you kind of already look good, and you might actually get your foot in the door that way, but you've got to deliver on that interview, okay? You have to deliver on that interview. Um if someone is looking to learn these ABG skills, what course would you recommend? Or maybe a college also for that. Okay, yes, I do recommend something. So um what I could recommend is you could do it two ways. So I did a Cert 3 in pathology, and that gives you the qualification to work as a phlebotomist. So they call it like a blood nurse, and you can work in the community or you can work in the hospital. And so I did both, but I mostly started out in the hospital. So that basically, I was really good at anything venipuncture, ABG, VBGs. And so, not just that, like, it's not just the art of taking the blood, it's knowing what Australian equipment looks like, because there's 3 different types of equipment you can use, knowing which ones to use for which patients, also dealing with very difficult bleeds, because in the community, everyone's easy to bleed. They're healthy. Go to a hospital, cancer patients, post-op patients, 99-year-old post-op patient, collapsing veins. That actually makes you really good at taking bloods. And that sort of made me really good in the hospital when I did my internship, because I was just like far better than anybody else. And also I knew what tubes all the bloods go into. I knew the testing requirements. Like even my reg wouldn't listen to me when we were in a met call, and the patient had really bad veins, and they took bloods from the side that the patient had fluids running, and I was like, you can't do that, because the results are going to be inaccurate. Cannot do that. You have to stop the fluids for 20 minutes, come back, and then bleed from that side that the cannula's in. And no, it's fine. I'm like, you can't do that. And then they gave me the blood. He walked out of the room, and I binned it, and I took bloods from the patient on the other side, because I'm really good with crappy veins, so I knew I could do it, and so I sent it down properly. So there's so many things like you're just really good at when you do those sort of things. So you could do that. You could do a Cert 3 in pathology, and then at least you have like a job after it that you can work in. And it's very advantageous when you do get a job in the Australian system, because you know what all the equipment looks like. Or you could do a 2-day course. There's a lot of private colleges that actually do cannulation and venipuncture 2-day course. And they're about $500. You get a certificate. Now, when I say you get a certificate, there's a difference between an IMG company running a course and you'll get a certificate. They can print it out, but it's not a nationally recognized certificate. The hospitals will still acknowledge it. Don't get me wrong. They'll be fine with it. You did a course. Yeah, great. It doesn't mean anything different on their end. But when I say like these private colleges, if you're an Australian, you know something called TAFE, you know that you do certain units at TAFE and they're nationally recognized. So when I mean private colleges, they're basically doing a unit in these nationally recognized courses. They take that unit out and you just do that unit and you get a certificate, and that's nationally recognized. And if you ever go to complete the entire course, that unit is recognized, and you don't have to repeat it. So that's what I mean by that. But definitely do a cannulation and a venipuncture course without a doubt in my mind. So my cannulation was really rusty, so I went and did a course before I stepped into the hospital, and just because you want to know like what the equipment looks like. So when they say go get the equipment, you know exactly what to get. And you're like, does this patient need a short bung? Do they need a loop bung? And if you don't know these words, this is what I mean. Like, you just like, what does that even mean? So there's little equipments and variables of equipment that you should know about. And so that I thought was really, really good. Yeah. Someone said, I totally agree working in ED and also nurse practitioners in fast track. Yeah. So that's what it's called, fast track. So it's still emergency, but fast track is like where all the GP type cases that the GPs who work in ED and the nurse practitioner can deal with. They had all more 5 years experience in resus. Yeah, they're amazing. Honestly, the biggest resource that most people don't know about. Um, do all hospitals have the medical education administration position you hold? No, not all hospitals do. Um, Mainly because they've got to fund that position. And if they do, it's never held by an IMG. I I had to prove myself to get that role. I really, really did. And I had to like honestly make a name for myself. That was the other thing I was going to say to you guys, that in my intern year, when I got that phone call, as I said, from my director of clinical training who was questioning my commitment, they didn't know me. And so the following year, once I did my internship was out of the way, when they asked for um, junior doctor reps for the IMG committee and for the junior doctor committee, I put my hand forward because I was like, these are committees that you, so I was the IMG committee rep. So these are committees that you attend, the director of clinical training there, all the big players are there. And you then represent issues that are coming forward and you're like a spokesperson for your IMG community. I was like, I'm going to do this because I also that's just my natural personality anyway. I hate poorly run things. But also, like now in hindsight, I realized that was such a great opportunity for the director of clinical training to get to know me and just show my initiative. I never ever had problems without solutions. So when I would come to them, I'm like, this is a problem, but these are a couple of solutions I'm thinking of that would really work and would really help. And some of these stuff were like resources that I created. I'm like, I've created these resources because at that time, like things weren't getting done. So then when I went for the medical education registrar role, I really, really pled my case to the director of clinical training. I was like, I can do this. And they didn't even know that I had education background teaching at private colleges before this, like creating content, creating resources, creating a curriculum. I have done this before. So I really pled my case and fought for that position. And yeah, so like it's as an IMG, sometimes you're overlooked for positions. So you have to really fight and advocate for yourself. Someone said, after listening to how supportive you are, I'd love to have an opportunity to work with you. If you're comfortable sharing with what hospital by any chance, it'd be wonderful. So I haven't started at my new hospital. So this year I'm locuming because now I've got general registration. I have freedom and we're going to do a podcast on locuming because there's so many things about locuming you need to know. The idea behind it is I'm back in New South Wales and I just want to test different hospitals out before I completely commit. I also want to do more of code dues. So I don't want to completely sign a contract tying me down to a hospital 5+ days a week. So at this stage, I'm going to a hospital, I'll just say in the southwest of Sydney. And my contract is for a month and I'll review if it works out. I might stay. If not, I might move to another hospital. I'm also juggling dropping my kid off at my mom's. So I'm trying to see if like this hospital works with, driving and drop off and pick up and stuff like that. Thank you. Your experience is one of the best guidelines we can get. Thank you. Um, are there any alternatives for internships in Australia for IMGs? No. If you need an internship, you need an internship. That's it. There's absolutely no other alternative way. So the only other option, you go back overseas and you complete the internship there, which means you also get recency of practice and then you come back here. If you're going to go overseas, try to make the internship look very similar to the one in Australia. So like 47 weeks of supervised practice. So full time and at least 10 weeks in medicine, 10 weeks in surgery, 8 weeks in ED. And then you'll be okay. So if you're going to go there, just make sure you reduce as many risk factors as possible. Working as a medical officer could be an alternative to an internship. So an intern in Australia is a medical officer, but you cannot work as a PGY2 medical officer if you haven't done an internship or if APRA doesn't recognize your internship. So there is no option to work as a PGY2 and above if you haven't done this PGY1 thing. So if you already have, then yes, you should go ahead and do a PGY2 plus job. Okay. For IMGs, do we need APRA verify your internship certificate? They do. Sasha's one because she did an internship overseas, so she knows a bit more about it. But they look into your internship, so your certificate needs to be verified, and they look into what compromises, um, what is compiled into what your internship looked like. So, for example, if your internship was like all in urology, that's not an internship. They won't accept that. So they actually look into that. And clinical gap after graduation doesn't matter. It kind of does because when you look at it from the admin side and you've got 80 applications and you haven't worked as a doctor, um, and let's say you got a 5-year gap. So you did your internship in your medical degree and you haven't worked as a doctor, and then someone else is applying who's worked as a doctor even for 1 year and they've got a gap, they're probably going to go with the person that's even 1 year. So when you hear Dr. Faraz's podcast, which will be the start of it will be in 2 weeks, with a 3-part series. He graduated med school in India, and he basically kept coming to Australia on a tourist visa, trying to like do AMC1, suss out how to get a job, flew back, worked for a little bit, came back, went back, worked for a little bit. So his PGY 2 year was like in drips and drabs. It was a little bit here, a little bit there. And that's what his story is amazing because he's saying it like it's how you present yourself. So he's in observership, how you present yourself really like can counteract how you look on paper. Um, so you've got to factor that in. I would say, like, is there any way you can get more recency of practice, even if it's for 3 months? Because that resets you. 3 months of full time work will reset that recency of practice. Is it if we already finished our internship in our country? Is it still necessary? It's necessary? No, it's not. You can go apply for roles beyond internship, like PGY2 plus. With a 10-year clinical gap, can we apply for an observership? Yes, you can. But here we go with the but. Some observership programs are more competitive than others. So in the hospital that I worked in, our observership programs were very competitive. The reason being is that we generally hired from the program. So we were already hiring people that could potentially be ready to work. So if we hired them, they did good in the observership program and they did good in the interview, they were ready to work. So somebody with a 10-year clinical gap, we would think that even if they do good in the observership program, even if they do good in the interview, we might not get them through APRA with a 10-year gap. So it was riskier. So we wouldn't go for those people. So other observership programs, it doesn't matter, they'll just take people. But I would say that, especially if you're going to pay for it, make sure that if they're going to take you, that there is potentially like a job waiting for you if there's one, because some observership programs don't have many positions for observerships, for doctors, for jobs anyway. Like the hospital's pretty well staffed and it's usually staffed with locals, so that's not really a observership you want to do and you want to pay for. A 10-year clinical gap is like Dr. Maria's story, which we filmed yesterday. So she had to end up going backwards and they had to give her an internship. But she did the observership, that she interviewed great. They didn't have an internship position available. A year later, they did. And then she got that. So that's how you can sort of work around the 10-year gap. But it's very difficult to get an internship as it is. And the reason she got one is because her partner was working at that hospital as well. So they remembered her. So I've got to really point out that there's key factors into the way this played out for her. So I just want you to be very aware of that. Best thing you can do would, if you can, go overseas and work for 3 months, or try to find an internship position. If the internship is not good enough, can you complete what is missing? Like you need more weeks in an area. You can't, if your internship is not good enough, you can't complete it in Australia, the areas that you're missing, because they're like, nah, you need an internship. That's it. You just need an internship in Australia. What you could do is, it'll be hard because like it depends on how ARPA is going to approve it or not. So if, for example, you completed some of the internships 6 years ago and you're coming back to complete the other parts that are missing, would ARPA consider that as an internship? Your country might offer you an internship certificate, but when ARPA actually goes through the nitty gritty of it and realizes, well, hold on here, half of it was done 6 years ago and the other half was done now, will they, will they pass it? The answer is I don't know. It really depends on the ARPA medical officer who's picked up your application, and then it goes to the medical board, and then it's up to the medical board to decide. What I would say is try to reduce the chances and the risk of that happening is by not doing that and just like completing a proper internship. Pre-graduation internship of 13 months, is it acceptable? Lots of overseas IMG doctors do internships before graduation. It's actually part of their graduation. So you cannot become a doctor unless you've not done an unless you've done an internship. That's pretty common. ARPA is pretty used to that. So as long as your 13 months was full time and you did ED, medicine, surgery, I think you'll be okay. So I've passed my AMC 1 and language requirement. How long will it take approximately for me to get a job offer as a PGY2? So they've done their internship overseas. So again, like back to what I was saying, how long is a piece of string? It depends on your recency of practice, depends on how good your CV looks. It's really, really just depends on those factors. Some people really quickly, some people really long. If you're not presenting well enough on paper, with your CV and not impressing enough, you might not even get looked at very easily. Also, apply through the campaigns. If you've got a massive clinical gap, try to do something about it. Try to like fill it up, go back, work for about a month or 2 months or 3 months is ideal, but I can understand a lot of people have families that can't do that. So anything to make the recency of practice look good and your CV look good. So how it actually presents your CV. You don't need to do like a PhD in anything to make it look good, like just how it looks. So yes, it's very hard, but again, observerships could be a good option. You don't need an observership to get a job, but sometimes you do need it if they just need to see you and see how you perform in person and how you present. That's such a big thing. Okay, well that's all the questions. So this live went much longer than I even imagined, but I don't know why, because I am a talker. So I hope it was extremely useful to you guys. We're going to try to do more of these, more just talking podcasts. So, less editing for us involved, but more just more filled with information, like genuine conversation. I think that's really important. YouTube's going to save this and it's going to go up to YouTube. So you can rewatch, you can take some notes out of this. Hope you found it extremely, extremely useful. The next podcast will be our IMG success stories, and that will start off in 2 weeks with Dr. Faraz, and it's definitely worth listening to that. And the reason we're doing this is because, like I said earlier in this podcast, all I ever heard was negative stories from people and don't do this, you can't do that, you can't even apply here. And it was all rubbish, to be honest. But we only repeat what we hear from other people. So we absolutely want to change that culture amongst the IMG community. We want to provide proper information, but we also want to share unique stories and see how other people went around certain issues that came up. And I think that's going to completely provide everyone a bit of hope, which is what we've kind of been missing from the IMG community. Just the last question is really important. Does a research work count as recency of practice? No. The only thing that counts as recency of practice is actually working as a doctor. That's it. Not even as a physician assistant, because we don't get those here. Nothing works as recency of practice. Nothing counts as recency of practice. Only thing is actually working as a doctor. That's it. So research might look good on a CV, but honestly, I stopped looking at people's research with CVs because it never really indicated the type of doctor that they were. So it holds less weight. It's really your recency of practice, how you present on paper, than how you present in the interview that matter. All right, everyone, thank you so much. I'm going to end the live here. Thank you so much for joining in. I really thought I was just going to present to like one person. And the questions have been fantastic. Some of the stuff I wouldn't have even thought about myself to answer. Thank you so much, and I'll catch you in the next podcast. See ya.